Welcome everyone. Happy Thursday, almost the end of the week. Hope you're having a good day. So before we get started, I'll just introduce myself. We have Morgan in the chat today before we dive into some EKG basics. So my name's Rachel. I'm the program director and a nurse practitioner here at Archer Review. And I'm super excited to bring you one of our free webinars. If you're not already part of our Facebook group, I want you all to go ahead and join that. That's the one down here with the arrow. And that's because we post all free content there. So free practice questions, you can message us anytime there, put any sort of questions about your exams, about school, really great place to get a hold of us. Also following us on Instagram. We are about to do some giveaways on Instagram, so definitely want to be following us for the holidays there. And then, of course, if you have nothing else, you definitely need the question bank. I recommend to my students doing at least 1,000 questions before testing. Good news, our question bank has over 1,600 questions. It also has a readiness predictor, and our students who get highs or very highs on the readiness predictor pass their exams. So a really great place to assess your knowledge, see those knowledge gaps. And then once you have those knowledge gaps, you can move over on to our on-demand or SurePass option. So on-demand is recorded videos. Along with that, you also get free PDFs and cheat sheets. They are broken down into bite-sized content, need to know. So we don't really dive deep on these topics, and that's because we cover what you actually need to know for your exams. You've already been through school, so you know what you need to know for school. These are what you need to know for your exams. And then we have SurePass Pro, and this bundles everything together. So this is our QBank, on-demand, and live review. And if you have SurePass Pro or SurePass, you can get the live review recording, which is unique. You can also just sign up for the 3-day live review, but you don't get the recording. SurePass Pro also has a mentoring aspect to it. So you do get a tutoring session. So to wrap it all up, to see where to start, whatever you want that to be. So really great value, really student-friendly pricing, because we know school is sure expensive, and a lot of you are cutting your hours and your jobs to make school and clinical. So we really try to make it accessible for everyone. So you can scan this QR code to register for SurePass Pro. You can join our community with this little QR code. If you have any questions ever, you can always email us at nursepractitioner@archerreview.com, and I will get back to you on that. I usually am pretty quick with the emails and happy to answer any sort of questions. So without further ado, before we jump into it, where is everyone joining us from today? I'm up in Massachusetts, where it's pretty cold right now. And Morgan, who's in our chat, is in Colorado. Unless you're traveling right now, you're always up and about. So two kind of cold places. Is anyone joining us from somewhere warmer? You can put that in the chat. Oh, Texas. We have we're based in Texas, so a lot of our team lives in the Dallas-Fort Worth area. Not me though, unfortunately. New Jersey. Okay, so a little cooler up here. Ontario, definitely colder than here, although beautiful area. Mississippi, a little bit warmer. Chicago. I keep saying I need to get to Chicago. What a cool city. So everyone's joining from kind of all over. I'm super excited you've decided to spend this time with us. If you miss anything or want to rewatch it, it will be available on both our YouTube and our Facebook page. So, you can always go back and watch it at any time. We also have all our recorded webinars there. We do pediatrics, musculoskeletal, GUI, STIs, pretty much every topic that's going to be on your exams exists in our free content. So you can always go back and watch it. But without further ado, let's jump into some EKGs or EKGs. I say EKGs. I work with many people who say ECGs. It seems like a split in the medical community, but we can call it both. So this one says EKG, this one says ECG. So let's first talk about lead placement. So most ECGs or EKGs have 12 lead placements, right? And before we get started, what is the EKG actually measuring? Who can tell me that? You can throw it in the chat. If you want to do anonymous as well, you can go to the Q&A and there's an anonymous section. So if you want to ask a question anonymously, that's totally fine. Well, what are we measuring with an EKG? seeing some correct answers across there. Yeah, heart rhythm, heart conductivity. So we're really looking at that electrical system of the heart, right? So unlike something like an echocardiogram where we're really looking at the structure of the heart, we're doing that ultrasound. This is measuring the electroconnectivity of the heart. So I like to break up the leads. So it has 10 electrodes on the body and then 2 on the arms and or legs. Some places specify they must be on the actual legs. Some nowadays allow it to be more up in the hip area here. So it doesn't always have to be down right leg, left leg. Some allow it to be on the hip area where those femoral arteries are. So if you're doing these in practice, in my own practice, I know how to do them, I promise. My MAs or RNs usually are just the ones actually doing them. But it's good to know, right? If you can't find someone, if you need one quickly, we use these to rule out the big scary things like MIs. So always good to know where they go. V1 up here goes in that 4th intercostal space to the right of the sternum. V2 is same thing on the left side. And then V3 is midway between V2 and V4. So I actually put on 1 and 2 first, and then I put on 4. And that's because 4 is at that left intercostal space at the mid-clavicular line. So this is the left side of the patient, right? And this is the right side of the patient. So I put on 1, 2, 4, and then put 3. It goes in between 2 and 4. So just a little trick there to have better placement. V5 goes level with V4, anterior axillary line, so more to the left side. And then V6, again, these 3 kind of go in a little line on that axillary side towards the left. So most things go on the left side of the body, which makes sense, right? The heart kind of shifts to the left, and then a couple on arms, legs, and 1 on the right side. Knowing this is helpful because if you get a lead error or like an artifact in a lead, you can figure out which one is causing it by where it is. Most are labeled right on the little leads themselves, so you can just fiddle with that and see what's going on. And when we're looking at the electrical conduction system of the heart, right, we have the sinoatrial node. So this is just the pacemaker. This is our big important guy in the heart. That is located in the right atrium. A normal adult pace is about 60 to 100 beats per minute. Some athletes have a little bit lower, right? I've actually had patients in my office who have like 40 heart rates, and that's normal for them, although it scares me a little bit. In an older adult, definitely going to be investigating that. And then, so that SA node is going, let's say, make it easy on us, 60 beats per minute. So 1 beat every second. The ventricular rate is a little bit slower. So it goes SA node, ventricles, SA node, AV node, right? That atrioventricular node. So, you know, the lub, the dub, the lub, the dub. And the dub goes a little bit slower, right? Because we have to wait for that electrical connection to come on down from the SA node all the way down the AV node, up the left and right bundle branch into these Purkinje fibers, which are the little ends of the electrical conduction system. So a typical ventricular rate is about 30 beats per minute. So 1 beat every 2 seconds. And when we're looking at an actual EKG, we're really looking at that PQRS complex, right? Like that's really the meat and potatoes of what we're reading if we're trying to figure out, is this normal? So how does this translate to the conduction of the heart? So P, that first little bump, right? It goes in alphabetical order, is that atrial depolarization. So again, that atrial node goes first, then the AV node, those ventricles. Then the QRS is ventricular depolarization. So we have the, kind of just follows what we just said, the atria go, then the ventricles go. Later on, the ventricles repolarize. And if you're asking yourself, where do the atria repolarize? It's actually in here too, but it's just covered up by the ventricles repolarizing. And that's that T wave afterwards. So it does happen. We just don't pick it up on our EKGs. So putting it all together, this is what it looks like. And we also look at the intervals, right? We're always measuring those intervals because that tells us if there are things like delays in the conduction of the heart. So the PR interval is the time from the P to the QRS complex, right? So that P right here to the R, and we're looking at that segment. The ST segment, which I'm sure you're all familiar with because that's where we see ST elevation, which we'll get to in a little bit, is from the start of the S to the start of the T. We also have something called the QT interval, which is important because some medications prolong this, right? Who can name a medication that prolongs the QT interval? There's quite a few. One I'm thinking of right off the top of my head is one that people might want when they're nauseous. Seeing some correct answers here. So yeah, Zofran, aldosterone is one that can lengthen that QT interval, which is why the arguments against putting it over the counter, although it would be nice over the counter sometimes. So a typical PR interval, and again, we're counting boxes here, right? So we are counting these teeny tiny boxes. The PR interval is about 0.12 to 0.02. And that's 3 to 5-ish boxes. Again, there are normal variations. Our QRS should be less than 3 boxes, so less than 0.12. And there should always be an upward deflection of that. That's called a positive deflection. We always want that QRS to be pointing upwards. Downward deflection is called a negative deflection, so it's moving away from the electrodes. So to break down the boxes, we have 0.04 seconds, which is each of those tiny little boxes, times 5, times 0.2 seconds, times 5 is 1 second. So you see these big boxes are made up of 5 of the little boxes. And you might be asking, why is this important? And it's important because if we're wondering, oh, do they have QT prolongation? We can count out the boxes. However, most modern EKG machines put the little intervals for you. And though we cannot always rely on the interpretation by the computer, we certainly can rely on the counting. But if you want to count them yourself, you can get down there and count the little tiny boxes. It's good practice too, which I'm sure you've all done as nurses. So when I look at an EKG, I really like to have a systematic approach. I try not to look at the interpretation at the top, although it can be very tough to not look at it, but it's not always right. I've actually seen some doctors put ones out here that the EKG read as normal and the patient was actually having a myocardial infarction. So we don't always want to go off of the EKG machine reading them as normal. But I first look at general impression. Does it look like these nice little boxes like this? If so, okay, great. Check that box. No ST elevation, no, wonky waves going on. Good. Then I look at rate and rhythm. So is everything evenly spaced? And I'm sure you remember from nursing school or being a nurse, you can kind of march out those keys, right? Make sure they're equally spaced from each other. And you can look at the rhythm. Is this a normal, regular rhythm? Then I look at the QRS axis. Is it moving up in the correct direction? Does it look really wide? Is it really skinny? What's going on there? Then I start to think about things like hypertrophy or ischemia or infarction. So let's start off with a nice, beautiful, normal EKG. Most do not look like this, and I don't want you to worry about that. So this might be stuck in your head, but a lot of times we have artifact, we have slight abnormalities, but they're not necessarily things that need intervention. But the basics, and again, this is written out generally on the EKG printout. The PR interval is 0.12 to 0.20. QRS is less than 0.12, rate between 60 to 100. We see it is nice and normal here, right? So these QRS complexes are all nicely spaced. None are small and then big and then small and then big or big and then small. It's all nice and even. We like that. That's what we want to see. And that normal QT interval also does depend on male or female, also depends on children, but we're just going to focus on adults right now. In men, it's about 350 to 450 milliseconds. In women, 360 to 460. So a little variation there. But again, this is really what we're looking at. Breaking it down to our basics again, looks pretty normal. General impression, rate and rhythm are nice and normal. QRS axis is in the right direction. There's no signs of ST elevation or anything wonky going on. And a little bit more about that QRS axis. This is where we look to see if there's ischemia going on. So this is a really nice diagram here that can show us what leads and what axes these go off of. Again, you're not going to learn everything in this one little webinar, but if you just, slowly absorb this information, it builds on itself. I promise. I'm still not an EKG expert, and I have been in practice for many years now. So just build on this information. You don't have to understand it all today. But why this axis is important is the axis can be displaced, and that generally tells us there's some sort of hypertrophy or enlargement of the heart going on. The axis is always going to be displaced towards the hypertrophied side. Same but opposite for an infarction or an MI, the axis points away. So the way I remember this is if they have an infarction or an MI, I'm sending them away to the emergency room. Where someone with something like left ventricular hypertrophy, yes, I need to investigate, but this is not a huge emergency. Obviously, if they had other things going on, notwithstanding, but in general, MI, we're sending away to the emergency room. So that's how I remember it. So that ischemia or infarction, that's what the big scaries, right? So again, if you ever see this ST elevation, red flags, doesn't matter what the EKG says, right to the emergency room, bad things are happening. So we can see the 3I triad. So ischemia, number one, we see that T wave inversion. So it's going the wrong direction. Injury, ST elevation, right? If a patient's having an MI, there's an injury going on to their heart. And then ST depression is an infarct. So again, if we're ever seeing ST, really, if the ST waves are looking weird to you, it's never wrong to refer out to higher care. That's really the number one thing we're looking for. Everything else can generally be dealt with, but that's the big scary one. So now that we've talked a little bit about it, and again, I know this is a lot of information, but we will get through it. Let's do a little practice. Patient number one is a 62-year-old male presenting to the clinic with complaints of worsening exertional dyspnea. So that's shortness of breath while moving over the past 6 months. He denies chest pain, palpitations, or syncope. His medical history includes hypertension for 15 years, which has been suboptimally controlled. So very common for our patients. His blood pressure today definitely elevated at 160/95, heart rate 82, regular. No JVD, so no jugular vein distension, nice and normal on exam. His apex beat is displaced laterally to the midclavicular line. On auscultation, we do hear an S4 gallop, but no murmurs, and his lungs are clear. So, being the good NPs that you are, we get an EKG, and this is what it shows. It is showing that left axis deviation. So lead 1 is a nice positive QRS deflection, lead AVF is negative, and lead 2 is predominantly negative, confirming this left axis deviation. What are our initial thoughts? Again, he's having like this shortness of breath, having a harder time over the past couple months. He's not in acute anything right now, but he's definitely having a harder time. What are we thinking about? Seeing a lot of great answers. I love it. I love it. EKGs are tough, you all, and you're really working through them nicely. So the thing I'm really focused on is this left axis deviation. So when this is deviated to the left, it's definitely making us suspicious for left ventricular hypertrophy. So likely due to that long-standing hypertension, right? So there's extra pressure on the heart. That muscle builds up around the heart and is hypertrophied, right? So it's bigger, just a bigger muscle because it's working harder. The heart is a muscle. If you work it out more, it's going to get bigger. However, unlike other muscles, the heart is not actually a muscle we want to get bigger, right? So definitely blood pressure optimization. So we could start them. I just threw out some examples here, like an ACE inhibitor is usually my go-to without contraindications like decreased kidney function. Lisinopril, usually covered by most insurances. Calcium channel blockers are good to add in to get him down to that target blood pressure. With calcium channel blockers, what is that pesky patient complaint that they sometimes have? More so with nifedipine, I find, than amlodipine, but what is that pesky complaint? Yeah, lower edema, swelling, sometimes some headache, but yeah, a lot of my patients that I put on calcium channel blockers come back and say, you know what, Rachel, my ankles are not fitting in my shoes anymore. So we have to come up with another plan. The nice thing about calcium channel blockers is you don't have to monitor labs as frequently like you do with ACE inhibitors. So for patients of mine, you know, who I really know don't like getting their blood work done, I do try to go calcium channel blocker for them. That's just a little practice pearl there. Additionally, for this patient, we're definitely going to get an echo, right? Definitely need to get a look at that heart. What's going on there? And then we're going to always modify that lifestyle, right? Sodium restriction, getting some regular exercise in, losing weight, smoking cessation, all those things that just promote overall health. We definitely want to reassess his blood pressure control. 4 weeks is standard. I actually bring my patients back a week after starting meds just to make sure they're okay on them, right? If they have lower edema and they stop taking their meds and they come back to me 4 weeks later and they haven't been taking their meds for a month, then that doesn't really do me any good. But if I know a week later that they're not going to take their meds, that's a little bit more helpful. And then we can always repeat an EKG if clinically indicated, but typically not unless they're having some more symptoms. Now let's talk about arrhythmias. So our first one is sinus bradycardia, and this can be totally normal, right? So this is just a slow heart rate. This is a normal P wave, normal QRS interval, normal PR interval, but the rate is less than 60. Again, this can be normal, especially in sleep, inactivity, but sometimes with certain drugs or patients who are having an MI, this can be abnormal. So if we were monitoring our patients throughout the night, we're definitely going to see some bradycardia, but this shouldn't be happening in a person that doesn't really meet these criteria, right? Especially if you have like an 80-year-old in your office and their heart rate's like in the 40s, that's not good. That's not, unless they're like some super athlete or something like that. We always want to be asking questions, right? Some patients will say, oh, my heart rate's been slow my whole life. And then I'm like, whew, a little less stressful, right? But some patients can say, oh, that doesn't seem normal for me. Then we need to dig a little bit further. Can be induced by things like beta blockers, calcium channel blockers, digoxin, even electrolyte imbalances. So those are times when we really want to dig further in. We want to fix the cause if it needs fixing, right? If they're just an athletic person, okay, fine, doesn't need fixing. Your heart beats a little slower, cool. If they're symptomatic though, and this is not normal for them, we may send them over and they might have to do something like atropine, which kind of restarts the heart. On the flip side, we have sinus tachycardia. So this is a resting heart rate of a greater than 100 beats per minute. Many things can cause this. And how do we know it's a sinus tachycardia and not a ventricular tachycardia? I'm looking at something on this EKG. They look very close together. What are looking a little thin on this EKG? Yeah, that's right. Those QRS intervals are pretty skinny and they're pretty close together, right? But looking through it here, we can see it's a regular rhythm. It's just faster. There's no irregularities, right? It's still a regular rhythm. It's just fast and close together. Different causes here. Patients could be anxious. Patients could have just run up 3 flights of stairs to get to your office. They could have extreme pain can definitely cause tachycardia, fever, caffeine, many causes that don't necessarily need prompt intervention. But there are things like hypotension or volume depletion or certain drugs that would need intervention. So again, we're going to try to dig through and figure out the cause. Moving on to an irregular pattern now, we have AFib or atrial fibrillation. So this is the most common cardiac arrhythmia in the outpatient population. Many people actually are just living with AFib, which is slightly scary if they're not on a blood thinner, but I digress. The risks increase with aging and people post cardiac surgery. So that's why they really warrant closer cardiac follow-up. Some people are asymptomatic and some people are not. Some people have this on and off, and some people have persistent AFib. So what we see here is there's no real P wave, right? There's just that kind of little squiggly line. We do see the QRS there, but we can't really measure a PR interval because it's not there. We can't get a good P wave. On exam, feel their pulse. If you ever find this on EKG, feel their pulse, and you can literally feel it. You can see right here, QRS further apart, closer together, further apart, a little closer, way further apart. You can feel that, or you can hear it too, So if you ever have a chance to, if you're ever being precepted or you see this, listen, because your ears can pick this up even before you get that EKG. So we definitely need to control that rate and get them on some sort of blood clot fighter, like an anticoagulant, antiplatelet, because the risk is there of what with these patients? Their heart's kind of beep, beep, then beep, beep. What's the risk for these patients? It's on this slide too, if you need a little brain boost. Yeah, clots. So that's really what we're worried about with AFib. And that's why people with prolonged AFib stay on anticoagulants their whole life. But again, we can intervene here. We can do cardioversion, and this can either be through drugs or an actual physical cardioversion, antiarrhythmics, beta blockers, and then if it's really bad or caused by something electrical in the heart, they can get an ablation. Some patients just have this if they drink alcohol or caffeine. And in those cases, we say, unfortunately, even if you like those things, probably not a great choice for your heart. AFib's cousin, a flutter, has this really distinguishable sawtooth pattern or wave pattern, right? So this has that atrial ectopic focus, but fires rapidly. So that's why you just see that sawtooth pattern. There's not even like an indication of any sort of PQRS. It's just sawtooth QRS, sawtooth QRS. This is typically more symptomatic, although it still can be asymptomatic. But most patients with a flutter have shortness of breath or syncope. So this comes into the ER a lot versus the outpatient setting. These patients may require pacing lifelong if this keeps happening to them. Again, we can do the cardioversion, antiarrhythmics, beta blockers, and ablation. So again, these two patterns are not necessarily going to kill the patient right now, not emergent right this second that they might die, but we really need to dig down and figure out what's going on. If they are symptomatic, we definitely need to get them over to the emergency room to figure out how we can help them and get the rate better controlled. So let's do another case study here. We have a 53-year-old male here presenting to the clinic with complaints of feeling like his heart is skipping, which is very common with these atrial arrhythmias. This started last night after a vigorous bike ride workout. He tried electrolyte drinks and some deep breathing, but he still feels panicky. His physical exam has a blood pressure of 150/62, so not too shabby there. His heart rate's 122, even though he's sitting down in your chair. His JVD, no JVD, so jugular venous pressure is normal, no murmurs, and his lungs are clear. What are we thinking with this sort of EKG? An irregular rhythm, P waves before the QRS complex, but they're very narrow, and his heart rate's about 125 on EKG. What do we think's going on, and what can we do about it? I see a lot of correct answers. So yeah, definitely suspicious for atrial fibrillation. For this patient, because he's symptomatic, we're definitely going to send him over to the emergency room. He needs some prompt cardiac workup and management. And a lot of times these patients also need fluid replacement, especially since he was on a bike ride. What electrolytes specifically are we looking at too when we're talking about cardiac patients, especially ones who might have sweat out a lot? There's two electrolytes that we're really thinking about. One that's really closely related to cardiac health. Yeah, definitely that potassium, right? So that can throw off our arrhythmias, and sodium. Sodium and potassium go hand in hand, especially if he's on that vigorous bike ride. He might have just sweat out all his electrolytes and thrown himself into AFib. So either way, he's symptomatic. He's going on over to the emergency room. Our last topic before we take a little Q&A is heart blocks. So we have 3 degrees of heart blocks, right? Our first degree, and any of these heart blocks, we're really looking at PR interval. So really easy to read out these heart blocks when you're reading an EKG because of that PR interval. So first degree, usually an incidental finding. So we find these a lot on EKGs of young, healthy people who need them for sports physicals, work physicals, things like that. And this is a normal everything, except for that PR interval is extended. So we can see this in this specific EKG here, right? It's just a little long. It's just longer than 0.2. So there's no dropped beats in a first degree heart block. That's a really important piece as we talk about the other heart blocks, right? So everything marches out nicely. We have nice spacing, QRS to QRS. Everything's there. It's just a little extended. Generally, in a healthy adult, this is just an incidental finding. Athletes can have this as well. There could be things like congenital heart defects, electrolyte disturbances. And in pediatrics, we always want to work this up because it can be a sign of myocarditis, especially in like that adolescent male population. We are thinking about this. So treatment generally not required unless it's something we can intervene with. Myocarditis, definitely treatment involved. But in a normal, healthy adult, it's just an incidental finding, just something we monitor. Second degree heart blocks are longer drops. So eventually that P wave is being dropped, right? So we can see this on EKG here. So it's pretty good. Then, where'd it go? So the PR interval keeps getting a little bit longer. This reads always abnormal on an EKG, and this has a little bit more worrisome causes like ischemia, myocarditis, sometimes just post-cardiac surgery. But we're looking to fix the cause here. If this is a symptomatic patient, they may need pacing, so they need to go over to the emergency room. If they're asymptomatic, this is something we want to dig into what is the reasoning and fix the cause if we can. But again, first degree heart block is just a long PR interval, nothing to do there. But second degree is where they're getting dropped, the longer drop. There's no P wave there. In second degree heart block type 2, of course, they had to give us a type 2, right? There's this rate instability. So there's not a QRS for every P anymore. So if we go back to type 1, there's still a QRS for every P, right? So we're still seeing that nice PQRS, even though it's elongated like that. In second degree, there's not a QRS for every P, and that PR interval might still be normal, but we're missing those QRSs. In a patient who comes in with second degree heart block and has a slow heart rate, we're really thinking about things like hemodynamic instability. These are patients we definitely want to pace because it can progress into third degree heart block. This is usually secondary to a structural heart disease. So type 2, I'm always thinking, what's wrong with the structure of the heart? Things like myocardial infarctions, cardiac surgery, inflammatory cardiac conditions like rheumatic fever, which rheumatic fever can develop after what? Very common throat complaint can turn into rheumatic fever if not treated. Who remembers that one? Yeah, strep throat can develop into rheumatic fever. So that's not one that we want to let go, right? We want to always make sure we're treating that. So again, they might need pacing. We're going to fix the underlying cause. It's most likely due to a hemodynamic instability. So we want to prevent it from progressing into third degree heart block. So now there's no QRS for every P, and you kind of get this variable PR interval. This is the most serious. That rate is very slow, and this is a failure of the AV nodal system. If you see this in practice, I want red flags going off in your head because this has a very high risk of progression to cardiac arrest. Usually they need a temporary pacing until a permanent pacemaker can be placed. So we're ever seeing third degree heart block or any sort of question of third degree heart block, emergency room. So these patients, again, are very unstable. They require the hemodynamic monitoring, fixing the underlying condition, and pacing in the meantime so they don't go into cardiac arrest. Usually they then require a permanent pacemaker. Obviously, we don't do that in primary care. So we send them out to the emergency room and then they're handled by the cardiac team. And we do have a nice heart block poem here. So if the R is far from the P, then you have a first degree. Longer drop, then you have a winky block. So second degree heart block type 1 is called winky block. Just think like it's not the same letter, but one winky block kind of sound the same, right? And then second degree type 2 is called a Mobitz or Mobitz 2. That's how I remember it. Or just like the M has two lines in it, kind of like side by side. That's how I remember it's second degree heart block. And that is if some of the P's don't go through. And if your P's and Q's disagree, then you have that third degree. That's that very serious heart block. This is just a little way to remember it. In the moment of reading an EKG, a lot of information's going through your brain. So if you can remember a silly little poem, it may help you to read out what you really need to know in that moment when you're reading the EKG. Of course, rely on the people around you when you're reading them. There are also some great resources we have here. So there's an ECG simulator. I happen to love this. And it's on skillstat.com and it just runs you through all these different EKGs, gets you used to reading them. There's also a famous book, The Rapid Interpretation of EKGs by Dale Dubbin. I do have that book. I think most schools require it. It's kind of like the founding book on how to read EKGs. It's very helpful. And of course, practice. So EKGs sound very scary and they feel very scary. And these are something, sorry, my internet slowed down for a minute there. I thought I lost you. These are something that just come with practice over time. So I hope that this was informative for you. Again, we have an EKG series. You can go back on our YouTube channel and look at that. I'll leave this up while I take some questions that you can put in the chat. Morgan's answering them too, but anything specific about Archer review or EKGs, or if you want to review something, let me know. And yes, please join us for our January live review. If you're graduating soon, it's the first weekend in January. Get you ready to pass your boards. The live review is the first weekend in January. Let me get my dates correct. I don't even know what date it is. The 3rd through the 5th. And you can scan to register up here for SurePass Pro, which includes that live review. And it also includes, where's my little cursor? There you are. It also includes the recording and the on-demand. SurePass runs throughout the year, so you can always sign up for SurePass. You'll get the unlimited access to the on-demand videos. The question bank comes with that. The mentoring comes if you have SurePass Pro, and then you can choose what live review you would like to attend. And again, if you can't attend the live review in person and you have SurePass or SurePass Pro, you can get the recording, which is really nice for you to review. Any other questions? I'm so glad you all joined us today. I know EKGs can seem scary, but on your boards, I want you to know if you even see an EKG, it's going to be an easy one. You will absolutely be able to read it. They don't throw scary things at you because you're a novice nurse practitioner. They just want to make sure you're entering practice and you're safe to practice. All right. Any last questions before I let you all go? Of course, if anything comes up, you can always email us at nursepractitioner@archerreview.com. And we're happy to answer anything. Definitely follow us on socials. Join our Facebook group. You're free to ask any questions there. We are always monitoring that. It was so nice being with you all today. I hope to see you in future webinars. Hope to see you in our live review in January.